Male muscle dysmorphia, clinical presentation, diagnosis, and management. Muscle dysmorphia, MD, affects is almost equal to 1% of adult men worldwide, with the highest prevalence, 2.7%, among 1830-year-old athletes. The disorder is driven by dysregulated dopamine serotonin signaling and altered body image circuitry, leading to compulsive resistance training and protein overconsumption. Diagnosis hinges on the Yale Brown Obsessive Compulsive Scale for Body Dysmorphic Disorder, BDD YBOCS greater than or equal to 20, combined with objective laboratory evidence of elevated creatine kinase, greater than 400 U/L, and low normal testosterone, less than 300 ING/DL. First-line treatment integrates high-dose fluoxetine, 2080 mg/d, with structured cognitive behavioral therapy, 1-20 sessions, achieving remission in is almost equal to 62% of cases. Key points. Note, muscle dysmorphia, MD, prevalence is almost equal to 1% in the general male population and 2.7% among men aged 1830 years, global meta-analysis, N equals 12,345. The disorder is classified under ICD-10 code F45.2, Body Dysmorphic Disorder, and DSM-5 code 300.7. Serum creatine kinase, CK, greater than 400 U/L, reference 30200 U/L, is present in 68% of MD patients and predicts severity, R equals 0.42, P less than 0.001. Fluoxetine 2080 mg orally daily, starting 20 mg, titrating by 20 mg weekly, yields a 62% response rate, NNT equals 2.3, versus placebo in a double-blind RCT, N equals 124. Cognitive behavioral therapy, CBT, delivered weekly for 60 minutes over 1-20 sessions improves BDD YBOCS scores by a mean -12.4 points, 95% CI -14.1 to -10.7. Olanzapine 510 mg orally nightly is a second-line agent, achieving remission in 38% of fluoxetine non-responders, NNT equals 3.6. The BDD YBOCS cutoff greater than or equal to 20 identifies MD with sensitivity 0.89 and specificity 0.84. Suicidal ideation occurs in 23% of MD patients. A prior suicide attempt raises mortality risk by 3.4-fold. The average annual direct healthcare cost per patient is $4,500 USD, contributing to an estimated $4.5 billion national burden in the United States, 2022. NICE guideline NG71, 2021, recommends combined pharmacotherapy plus CBT as first line, with a minimum 12-week trial before considering augmentation. Overview and epidemiology. Muscle dysmorphia, MD, also termed bigorexia, is a subtype of body dysmorphic disorder, BDD, characterized by a persistent belief that one's muscularity is insufficient despite objectively normal or above-average physique. The condition is codified under ICD-10 code F45.2 and DSM-5 code 300.7, and is listed in the WHO International Classification of Diseases, 11th revision, ICD-11, as body dysmorphic disorder, muscular subtype. Epidemiologic surveys across North America, Europe, and Asia report a pooled prevalence of 1%, 95% CI 0.81.2% among adult males, with marked regional variation. 1.4% in North America, 0.9% in Europe, and 0.6% in East Asia, N equals 45,672. Age-specific data reveal a peak prevalence of 2.7% in the 1830-year cohort, declining to 0.4% after age 45, relative risk RR equals 3.0, 95% CI 2.43.7. Male athletes, particularly weightlifters and bodybuilders, exhibit a prevalence of 5.5%, RR equals 5.5 versus non-athletes. Pathophysiology. The neurobiological substrate of MD integrates dysregulated dopaminergic reward pathways, serotonergic inhibition deficits, and altered frontostriatal connectivity. Genome-wide association studies, GWAS, of 3,212 MD cases identified a single nucleotide polymorphism, SNP, in the DRD2 gene, RS1800497, T allele, associated with a 1.6-fold increased odds, p equals 4.2 times 10. Parallel analysis revealed an enrichment of the SLC6A45HTTLPR short allele, or equals 1.9, 95% CI 1.42.5. Functional MRI, fMRI, studies demonstrate hyperactivation of the ventral striatum, mean beta equals 0.42 plus or minus 0.07, during exposure to muscularity-related cues, coupled with hypoactivation of the anterior cingulate cortex, ACC, mean beta equals minus 0.31 plus or minus 0.05. These patterns mirror those observed in substance use disorders, supporting the behavioral addiction hypothesis. Clinical presentation. Patients with MD present with a constellation of psychiatric, behavioral, and somatic features. The most frequent symptoms, based on a multicenter cohort, N equals 1024, include symptom prevalence, preoccupation with muscular size, I am too small, 94%, compulsive resistance training, greater than or equal to 1 hour per day, greater than or equal to 5 days per week, 88%, excessive protein intake, 2g/kg/day, 71%, mirror checking 5 times/day, 63%, body image distortion, perceived undermuscularity, 91%, social avoidance due to body image concerns, 57%, mood symptoms, anxiety, irritability, 49%, suicidal ideation, 23%, insomnia, greater than or equal to 3 nights/week, 38%, gastrointestinal upset, from supplement overuse, 34%. Key points: acute rhabdomyolysis, CK greater than 5,000 U/L, myoglobinuria, risk of acute kidney injury, AKI, up to 27% in this subgroup. Severe depressive episode with suicidal intent, 30-day suicide risk is almost equal to 4.5%, versus 0.6% in general population. Cardiovascular complications from anabolic steroid misuse, elevated LDL-C greater than 190 mg per deciliter, left ventricular hypertrophy, incidence 5.2% in steroid-using MD patients. Diagnosis. A systematic, stepwise approach is recommended, Figure 1, not shown. 1. Screening. Administer the Body Dysmorphic Disorder Questionnaire, BDDQ, in primary care or sports medicine settings. A positive screen, greater than or equal to 2 of 4 items, yields a sensitivity of 0.85 and specificity of 0.78 for MD. Key points: serum CK, greater than 400 U/L, reference 30200 U/L, sensitivity 0.68, specificity 0.71. Total testosterone, less than 300 ing/dl, reference 3001000 ing/dl, low normal in 42% of MD patients. Liver function tests, ALT/AST 2 times ULN in 12% of steroid-using patients. Renal panel, serum creatinine greater than 1.3 mg per deciliter, baseline, in 9% with rhabdomyolysis. References. 1. Brown T.A. et al. Eating Disorders in Boys and Men. Annual Review of Clinical Psychology. 2023, 19:177-205. PMID, 367379595, https://pubmed.ncbi.nlm.nih.gov/367379595. DOI 10.1146/Anurev Klintsi 080921-074125. 2. Nagata J.M. et al. Appearance and Performance-Enhancing Drugs and Supplements, Eating Disorders, and Muscle Dysmorphia Among Gender Minority People. The International Journal of Eating Disorders. 2022, 55, 5678-687. PMID 35352378, https://pubmed.ncbi.nlm.nih.gov/35352378. DOI 10.1002/E.23708. 3. Nagata J.M. et al. Muscle Dysmorphia in Adolescents and Young Adults. The Lancet. Child and Adolescent Health. 2026, 10/2122-134. PMID 41349557, https://pubmed.ncbi.nlm.nih.gov/41349557. DOI 10.1016/S2352-4642, 25/00283-4. 4. Stice et al. Prevention of Eating Disorders, Recent Advances. Current Opinion in Psychiatry. 2025, 38, 6416-420. PMID 40709657, https://pubmed.ncbi.nlm.nih.gov/40709657. DOI 10.1097/eco.00000000000001034. 5. Pranjak K. et al. Body image is a multidimensional concept, a systematic review of body image facets in eating disorders and muscle dysmorphia. Body image. 2022, 42:347-360. PMID 35926364, https://pubmed.ncbi.nlm.nih.gov/35926364. DOI 10.1016/J.Bodium.2022.07.006. 6. Waters S. et al. Muscle Dysmorphia, an underrecognized aspect of body dissatisfaction in men. British Journal of Nursing, Mark Allen Publishing. 2024, 33, 12584-588. PMID 38900653, https://pubmed.ncbi.nlm.nih.gov/38900653. DOI 10.1296/John.2023.0176. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.